with, because I've been reading online,
The
it's
t-shirt
a
thing.
t-shirt thing, so that it
School Board Workshop for Tuesday, February 16, 2021 to order. If you would, please join me in silencing your cell phones. And with that, we will begin the workshop. And Sarah, is this, which Sarah go?
She has to leave here
Yeah, it's
today.
me.
Okay.
Everyone says I look different.
Yes, so today is our quarterly health center and health program update for the school board. Our workshop, and we have our partners here. We have Barry Murphy from Mitigate, Ashley from Proventure, you guys know Kenneth with Rosencare, and then Carolyn with Proventure, and of course Lauren and Latasha, our risk management team. So I will turn it over to them to get started.
Okay, Kenneth, thank you. I guess I'm first.
Kenneth is first.
The health center first.
Well, thank you again for having us here. So we wanted to just give you guys an update. We did leave the pictures of a lot of the providers of your health center. And Dr. Thatch, right here, she's just returned. And Dr. Sarmiento just joined us. We brought her on back in November, but she was actually moving from Miami to relocate here. And she's Spanish speaking, so we wanted to have her picture up there for you. Again, these are our other providers, our two doctoral level PTs and Dr. Hughes, our chiropractor, and then our ophthalmologist is also on site. And we're going to actually talk a little bit more about the ophthalmology and chiropractor too in just a few moments. Here is just information for the month. We had some really good scores in relation to our customer service. I think it was about 4.80 is where we were at, and we're averaging right around there. We're in the 4 6s up to the 4 8s, which is really pleasing for us. Here we've got about 3,900 unique members, and we're doing things. I think I talked about it the last time, but I'm going to talk about it again. But we're bringing in other services within the health center to attract some of the population. So I was at a meeting with one of your group, and there was an individual there who had, I think she had been to the health center with the previous provider, maybe came one time with us. But then I started talking to her about ophthalmology and started talking to her about the chiropractor, and her eyes just lit up. She's like, I need an ophthalmologist. Oh, I would like to see a chiropractor. And so we took the time, I took her over to the health center, and she actually scheduled an appointment. So a lot of those other services were intentional, not only from a compliance standpoint, from a wellness standpoint associated to diabetes and other services, but a way to attract individuals to want to come to your health center, not only for the medical, not only for the physical therapy, for other services that they're looking for. Here, I don't know if I talked about it last month, but we did bring in Dr. Hughes full-time. He was only with us for a little over 30 days, and we were being intentional, trying to grow his practice, and it spread organically. People were talking about it left and right, and they were just encouraging their friends to come over to the health center, see Dr. Hughes, and we captured them, where he's now full-time with us, which is a great opportunity, not only from bringing people to the health center, but also for chiropractic medicine, also for wellness, also for feeling better, for pain. I think the last time we talked about somebody who came to see Dr. Hughes and the entire team was actually feeling better, headaches were gone, those type of things. Because as we remember, a year or 2 years ago when we were looking at some of your data, people were going to the emergency room for the headaches and for those pains. So now we've got those services at your health center. I wanted to spend a little bit more time. I touched on this the last time we got together, but I wanted to spend a little bit more time on it again, as we're focused on outcomes, not on how many heads in beds or how many patients can we run through your health center. That's not the point. The point is, what are we doing with those individuals to get them to better wellness, better health, so they're not ending up in the urgent care or into the emergency room. So one of those, let's look at this one, D03, the first one I highlighted, is the annual Hemoglobin A1c test, and it's specifically to the condition of diabetes. So you see, that's the diagnosis. And here, this is a cohort. So we took the population that are diagnosed diabetics, and we said, okay, who are we seeing? Well, we're seeing 293 of them, and we took that same cohort and looked at them from previously. Where were they before? Now, one of the things that I want to talk about is we all see in the newspaper that people are delaying care because of COVID. We had non-essentials that were delayed, screenings and prevention and vaccines all delayed. So we need to put that into the context of that happened to us too at the health center. Now, we're recognizing and we see areas that we can continue to go after, but still our numbers are actually pretty darn good compared to the benchmark and compared to where those individuals were before we took over. So hemoglobin A1c, that individual should be getting it, ideally every 6 months, but we'd want it every 3 months if we could. It's going to give us better control. The next is the annual microalbumin. And if you see, we have, we're 83% of the, again, diagnosed diabetics are getting their microalbumin. The microalbumin is looking for problems associated to their kidneys and is there any damage that could be occurring? And that's what we're looking for. And here, we're at 83%, benchmark 67, where was that same cohort, that same population before we took over, and they were at 68%. And you remember, you have, I was going to use ESRD, or end-stage renal disease patients. Well, how do they get there? This kind of stuff is how they get there. If we're not looking for it, they're going to have the damage. If they have the damage, they're going to be costing you $60,000 a year easily for dialysis, or we'll do a transplant. That's about $70,000. But now that member, that individual is going to be on anti-rejection meds for the rest of their lives, and they're not going to be working for you as a teacher for that period of time while they're going through the transplant. LDLs, area that we can improve on. Here, the LDL for the diabetics less than 100. That means if you're diabetic, your cholesterol level, we want it less than 100. And we have 40% of our population are less than 100. Look at where they were before, 23% for that same cohort before we took over. We have work to do, and we're going to continue to go after that. Could it be that they couldn't afford their meds? Could it be that they're non-compliant? Those are the things that we're reaching out to figure out. Another area, hemoglobin A1c. So if you're a diabetic, how do we know that you're actually controlled? Remember that hemoglobin A1c that we were talking about? This is a value, 7% or less. That's where we want that diabetic to be. Is it they're, again, taking their medications, or are they doing the right diets? Are they doing what they need to do? Same population. We're at 45%. We have a lot of work to do here, and we're going to get better at it, especially since we launched our glucometer checks. We're going to get better at that. But where were they before? So we're getting there in time. Now remember, COVID impacts a lot of this. Yeah, the rest is the same. The next one I wanted to look at was colorectal screening. So colorectal screening, we, it's one of the top cancers. It's people die from it, and it easily can be looked for from colorectal screening, such as colonoscopies, or if, there are patients who don't want to get a colonoscopy. They're going to fight it tooth and nail. So we've got at the health center an agreement that we're doing the Cologuard or other type of testing. It's better than nothing, because if that Cologuard comes in and it's positive, now that patient is going to get a colonoscopy, and we're going to be saying, well, guess what? We did the Cologuard, Mr. Thacker, we've got to go ahead and send you for a colonoscopy. But this will get us there. But one of the things that we did was we were able to bring in the Rosen discount for the Cologuard and extend it into the district. And so we were able to save, Carolyn, I think
$200 per test.
$200 per test. And you see, for our population, we've got 863 that are sitting out there. We have more than that. This is, again, just the people who are coming to the to the SDOC Health Center. But we're at 52%. We're going to do better than that. But where were we prior? 39%. Cervical cancer screening, we're doing pretty well, but I'd like us to do better than that. One of the things that we are going to be working on is really women's wellness. And we brought in the screening mammogram, we do better with that. But what about prevention? What about Gardasil? Why don't we try and prevent cancer, cervical cancer? And so that's where we're going to be really looking at for those individuals. And we'll provide that Gardasil from the health center. So that's something we're additionally working on. Screening mammograms, this is really impacted by COVID. We had to shut it down, but we're back up and running. And the bus is also going out to your schools, so we're making it as easy as possible. And then we have another pilot that's going on.
Substitute.
Yeah, you want me to talk about it?
We haven't done the substitute yet.
We haven't done it yet, but we're doing a pilot. We're in discussion with the pilot to figure out what can we do to increase the teachers attending that bus when it's on site. Now, 4.8 out of 5. People helping people. I'm gonna let, no, I'm driving.
So, last month, we always get such pleasure when we receive information from a member that they received exceptional care about something. For somebody to write an email or call us with a compliment is a really big deal, because they're quick to call with a negative, negative comment, but for them to take the time to actually write an email is a lot. So I need to get my glasses, and this one here is kind of chopped up. So this first one says, she wrote this letter to Dr. Pace and to Miss Diaz. Her name is Deborah Bear. Her and her husband, my hubby and I both retired on January 11th, 2021, after more than 35 years of teaching. They were both tired and wanted a slower pace of life. Retirement, here we come. One main issue was the type of health insurance I need due to the fact being too young for Medicare. After many months of reviewing our school insurance and others on the open market, I decided to stick with the school insurance. Fast forward to January 19th, 2021. I went into the health center for an updated blood work and some health issues I was experiencing. My PA, Giselle Lopez Rosa, that I'd met in June, listened to every word I said, as she always does, and set up x-rays and appointments for the chiropractor, who I now see for once a week for 4 weeks, and the eye doctor, and sent to Publix a few prescriptions. I could now continue with numerous actions this PA did for me with regards to x-rays, appointments, etc. But what caused me to write to you both today is the medicine prescription that I received today from True North. In August, after visiting my lung specialist that is connected to the district clinic, they put me on a trial medicine called Spiriva to help me with my COPD. I loved it, and they sent me a regular prescription to our old insurance with Cigna, but I couldn't afford it because the price each month was over $175. And that was the generic version, not the one that I tried with my lung doctor. So I told Miss Lopez the story, and she decided to send the prescription to True North, and it arrived today, free of charge. And when I called True North Pharmacy and I asked them how I got this medicine, simply they said they got it from Canada. I have tears of joy at this moment, Dr. Pace. Thank you for making the change to our new health insurance in the health center. I'm sure it wasn't easy to switch insurance, but you did the right thing. And I will be the first one to stand on the steps of our school system and say to all who will listen, I'm 63 years old, so I have 2 more years to stay in the district insurance, and trust me, I plan on doing just that. So those are nice things to hear when this is someone who, sorry, dry mouth, who was a teacher for 35 years and worked really hard to enjoy her retirement, but probably couldn't retire for very long because she has COPD and couldn't afford her medicine. So this changed her life. And with going with our program with True North, we get the medicine at significantly less cost and pass on that to the member, so she pays nothing and the school pays significantly less.
So,
Let me just add to that. I ran into somebody last week that said, I need to talk to you. And surprisingly, but most of the time when you get that, it's really great news. She kind of got me cornered a little bit, which was fine. And it's actually somebody I've known for a very long time. It's a very similar story because it's not the same person because the age is different. She has retired fairly recently, and she could not say enough things about our health clinic. And she's using a chiropractor, and she's doing a couple other things going on there. But she said this is making her retirement successful, is the ability to have this and the low cost and the not paying a deductible. And she's got actually 3 or 4 more years till she gets to the Medicare age. So it was a
Nice to
very
hear.
nice conversation, and she said, I will tell anybody, I'll tell everybody. So this is the greatest thing. I can't believe we're getting this. So
I mean, those are great validations of what, we're working together with you to provide to your associates, your team members, your teachers. There were several great points that I took away from this, but I wanted to bring us back to 2 years ago, or a year and a half ago, when we were looking at some of that Cigna data. and the COPDs and those asthmatics that were going to the emergency room because they were not on the medications. Well, here's a key example of what has been experienced with your new program. So kudos to you, Dr. Pace, your entire team, for stepping out because now you've made her retirement that much better. But not only that, she's now an advocate for your whole health system that you have created. And it's been a tough time, but we did it, and we did it for a purpose, and this is exactly it. I think there was another one, Carol.
And to Giselle for listening to her.
Yeah, so I'm going to show, wasn't there another one?
This one here.
Oh, this one. So I want you to look at the common variable from two separate providers.
So the first one, we got permission from the member to use her name and to use her condition. She felt that passionate about her situation that she said, I want everyone to know my name, what I have, and why this made an impact on here. This one, we were not able to get that, so I had to remove her name for HIPAA. So hello, I think this went to, Lauren. I want to share an experience with you I had this year. I had knee replacement surgery on June 15th. The surgery was the worst experience of my life. It created a lot of health issues for me, some of which were back pain and pain throughout my body, and that is just a few things that happened to me. The pain was the worst. I saw many doctors, including my surgeon, who was an excellent doctor in the Celebration area. No one would listen. No one would help me. No one. My coworker convinced me to try the health center. I did not want to. What would they do for me? No way. But finally, I decided to see what did I have to lose. I went there and was seen by a young lady, Natalia Brums. She listened to me. She gave me 4 referrals. It was the health center, physical therapy, the chiropractor, and an x-ray on my back. She also referred me to a rheumatologist. Because of this awesome young lady, I am doing amazing today. I've made great progress. Karen in physical therapy was hard on me and pushed me hard as I was very behind where I should have been after surgery. Today, I do everything I used to do. My back is doing wonderful thanks to your chiropractor. I cannot tell you how impressed I am by your staff. I don't know where I would be today without them. I have no words to express how grateful I am to a professional, amazing staff that saved me. All starting with a very young professional named Nalini, sorry. She actually listened, and that means everything to me. Merry Christmas. Please let them know they all have a special place in my heart.
So I'm hoping that you see these are 2 different providers, but the common word was they listened. And that's something we continue to work on with our entire staff. That's, it's a work in progress. We're not perfect, and we'll continue to get better. But here's 2 separate situations, 2 separate patients, 2 separate providers with the same result. They listened. And that's our goal, to give the providers the time, because in the traditional world of healthcare that we live, it's how many patients can I see? I got to see a patient every 7 minutes. It's heads and beds, volume, get them in, get them out, make me money. That's a different model than what we do at the Rosen and what we're doing at the health center. The model is wellness. It's controlling that 75 to 85% of your spend is on chronic care conditions. And here, take a look at those that we've touched. And we're continuing to touch. We're continuing to show outcomes associated to everything that we said we were wanting to do. And it's only the beginning. Those are the kind of things that we're bringing to the table. This here, just as a reminder, this is what the individuals would have done if you did not build your health center. If you didn't have your health center, what would they have done? And this is what they would say. They would have gone to urgent care, they would have gone to another PCP, they would have gone to a specialist, or they would have gone to the emergency room. And this is for the year. We didn't put a total.
It's from January 2020.
Oh, there we go. So almost $5 million. $5 million going to outside providers. And those outside providers wouldn't have been following up with your population or controlling the outcomes that we've been talking about. $5 million is what you've saved. And I think that's it. Yes, sir.
Am I recognized by the chair?
Sure.
Oh.
Kind of follow protocol.
And I'm still learning the protocol.
That's okay. Because I noticed that the provider was Lopez and somebody else, right? But on page 3, we have 3 doctors there. And I went to the website. I didn't have to see a patient, so I was like, oh, I wanted to try to, I heard rumors about how long it takes to get an appointment and stuff like that. So I try to pretend as if I was, meeting. And there's like 4 different variations. If you're a new patient or a visiting patient, and I tried all 4 variations, and none of them showed a doctor. They all showed nurse practitioners.
Right.
So are those 3 doctors actually here? And
They
how do you
are.
actually see a doctor?
They are. So Dr. Perez is there part-time. As I indicated, Dr. Thatch just came back, so we're going to be uploading her into the system, and same with Dr. Sarmiento. She's just going through her training. Once all that is done, they'll be put onto that site that you were looking at.
Now, is 3 physicians kind of heavy? Because most of the practices I go to, they're nurse practitioners. And the cost between a nurse practitioner and a doctor is more. Usually they have a doctor, be like the medical director, and you have nurse practitioners in the bottom.
Yes, your population screams from the rooftop that they want doctors. So there is a price variation associated to that, and that's why we have more nurse practitioners than we do have physicians, because you have some people that are hard staunch. I will only see a physician. Well, then we're catering to those individuals too. And then each one has a different level of board certification that they can serve that population.
But those 2 comments that came in
Or the nurse
were both
practitioners.
from nurse
Yeah, because
practitioners.
most of the time, like I said, I have a doctor's office, I never see a doctor.
Yeah.
I see a practitioner. So I was wondering, we're trying to save money, but we're kind of top heavy on doctors. And when I go online, I can't even see a doctor. You know what I mean? So I'm like, we're paying for doctors that
Yeah.
you don't
Yeah.
see.
So you can,
There are
you
appointments.
can, if you called the health center, you can get appointments with them. Again, we were just getting them back into the health center, getting them acclimated and getting them back up and running before we put that posted. Because once we put that online application, or not, reservation or appointment, it actually goes to our front desk. And right now, our front desk and our administrative team is getting slammed because of the wellness program that we just started. With the wellness points and those type of things. So they're calling the health center, trying to get appointments, getting in the screenings, all of that we're taking a beating right now. And that's something that I did not focus in on. I did not recognize that we were going to get hit on that aspect. I was like, okay, it's a wellness component, it's wellness points, but I didn't put the 2 and 2 together and to properly prepare us for that. That's all my fault.
So when can I expect the website to be updated to actually make an appointment with the doctor?
Pardon me?
So when can I expect the website to be updated to actually make an appointment with the doctor?
Oh, they
Oh, yeah.
are open.
No, it's not
Oh.
up there yet.
Oh,
No, I needed,
You
so
can
Dr.
call.
Sarmiento just started, I think this is her
second one.
second week, so probably in the next 2 weeks, she'll be up and running.
But we won't be able to make an appointment with Dr. Perez? Or-
He's there part-time, and so his schedules are full, and so we work people in when they call in for those appointments. So Dr. Perez is only there 2 days a week.
And what about Dr. Thatch?
Dr. Thatch just came back from maternity leave, and so we're working with her on her schedule, so as soon as that is solidified, and she's back up and running and back into the grooves, because she's been gone for
3 months.
3 or 4 months, 3 months.
And there wasn't a doctor filling in for them?
We did. We had some physicians who were filling in for them, and we didn't put them into the schedule because they were filling in for those providers, because we have to program and those kind of things into the online system.
Can I just add, and correct me if I'm wrong, but you can always call and request a certain doctor.
yeah,
They're just not showing up for you to click on the
Correct.
internet.
Correct.
Yeah, I mean,
If you
people don't know that,
specifically
they're
want to
not
request
really
someone, you can always call and.
Oh yeah, and most patients actually call versus doing the online scheduling.
Kenneth, would you comment on the status of and your plans for the Point Siena clinic location?
So the Point Siena, we are sharing that location.
There's some data already up there too.
Yeah, and it's pretty full. So we're talking to the individuals who we're borrowing that space from. That was something that we did not want the district to have to pay for a second site yet until we have proven that is exactly what Point Siena needs. And so we're looking at, can we add another provider out at that site? So we'll have 2 providers because they're only giving us 2 half-days. Then I'm also looking at another option to serve that Point Siena population. So more to come with that. It's really, we're in the assessment stage.
Mr. Chairman, if I may. So these doctors here, they are doctors on our payroll. Is that correct? On
Yes.
Our facilities?
Yes.
But none of them are full-time doctors.
These two are full-time. This, Dr. Perez is part-time.
And, okay, so one is coming back from maternity leave, one is a full-time doctor who started 2 weeks ago, who will at some point be full loads. Okay. Can I make it, well, this may or may not be the right time, but can I give you guys just I hate to throw this wrench into your presentation here. I think it would be better served if these presentations are a little bit less sales pitchy and a little bit more content heavy. And I say that just because I think this is my third presentation of this sort. The first one, great reasoning, right? You guys are introducing me to the plan. The last one was pretty good, and one of the negatives from the last aspect was the idea that, at least I got the impression, I may be the only one, and I speak for myself, that I got the impression that it's like, well, it doesn't matter, I won't address that, but I think like the testimonials and so on, those are good to hear. I think it'd be better served to send those directly to us and let them look and learn. I know that there's HIPAA issues there, but really, I'm far more interested in how this is benefiting us from a healthcare perspective, and when this is going to translate into our members having lower costs. And so talk about the savings, but then we talk about testimonials, and then we kind of look at these numbers, which are very useful. But I think that everyone here on the board agrees that this is good. What you guys have done is good. That you guys are on the right track, and and you guys are here, right? So maybe now, if we can, and I'm only one voice here, maybe focus on these numbers and how that translates, and what the trajectories are, that you guys are creating and so on, like on some of these pages.
So, I guess so you want me to equate dollars to some of these outcomes and measures?
I would like to see that. I mean, in some of these you have here that you have like this cost avoidance. To me, that's important. At what point does this translate into something that would become budgetary? Because I know it's not in our budget, it's a cost avoidance issue, right? But at what point does this cost avoidance come back into our members not paying $1,000 a month in healthcare, right? And I know that a lot of that is a district question. In terms of what we're seeing, the schedule, this late cancel, no show kind of stuff. An introduction to these doctors and so on. I mean, that's kind of good to know. This is a thick packet here, and I really am looking forward to seeing how this translate, as in terms of results and dollars and what our scope is.
Absolutely.
And I just want to piggyback and almost echo what he's saying. We may not disclose it, but we all hear some of the district employees that are still falling back, saying we want our old system back. We do hear it. So when you have any kind of program, the good news stands on its own. But you also have to look at what are some of your challenges? What are some of the negatives? Because I can tell you what some of the negatives in my business is. But the good news stands on its own. But let's hear some of the challenges that goes along with it as well.
Oh, absolutely. I can stand up here and talk about healthcare and all the negatives associated to it, front, left, back. So I will start whittling this down away from some of the introductory stuff, and we will start showing some more numbers. It's hard, very hard to predict. All we know is the average uncontrolled diabetic is going to cost you $15,000, and you are around that measure. Now that we're bringing them under control, that number associated to specifically diabetes should also come down. And that's the area that Barry and Ashley and all of us are going to continue to work on, is what are we doing here? How's it translating into savings? But as we continue to work together to bring in programs, it's not only oh my goodness, she can afford this Spiriva now. That's a savings to your members. It might not, Mr. Wheeler, it might not be a premium savings, but you saw, I can't afford $175 a month. So that's one piece. That's putting $175 a month basically into your teacher's pocket. But now on the flip side, her COPD is gonna be under control. On the flip side of that is, oh, guess what? You're gonna have more teachers saying, I wanna stay with Osceola County, I'm gonna retire here because of the program that they have created. And that's exactly what she said. So we'll work on not only presenting these outcomes, but I will show you statistically and from a national benchmark standpoint, what are these chronic care conditions costing you? And I've already said 75 to 85% of your overall spend is chronic care conditions. It's showing that we're preventing them going from those to the emergency room when they couldn't afford that Spiriva. They went because of the COPD. That's how we tie it all together. This is just showing you where we were, what are we doing, and the savings is there. We just need to do a better job of showing you, okay, what is the national benchmark of the cost of a diabetic compared to where we are today? These are the outcomes that show we're getting there. These are the outcomes showing where we can improve, and I've shown you where we can improve. And what we're doing to improve those measures where we have in these numbers where diabetics are not checking their blood sugar. Here, 35%. But we just instituted a program that's going to get those members that free glucometer. They can't afford it. They can't afford the test strips. They can't afford the Lancets. So how do we hold them accountable if they can't afford it? So the first step is, where are we? Next step is, wait, they can't even afford to check their own blood sugar. So let's get it to them. And oh, by the way, we saved you money. Oh, by the way, that colonoscopy, Mr. Aguilo, $200 per person is what we saved you as the district. That's just on the Cologuard. If we don't even need to do that colonoscopy, what did we just save you there? Those are all savings, but we're first going to make sure we get your teachers what they need to get to the outcomes that we can get them to and remove all the barriers to access to care. And that's exactly what your team is doing with you guys.
Ms. Castillo has her light on before.
Thank you, Mr. Chair. Thank you for that explanation. Mr. Arguello, if I may just make a suggestion, I think what we might need is a marriage between this presentation and our finance presentation. I think that translating these numbers into what it means for us in our budget is probably what you're looking for, and I'm not sure that this is necessarily something that they would have jurisdiction over. I think that it's possibly more towards Sarah. So I think that's, and I think that you're probably going to talk a little bit about that as well.
Next update is the financial.
Well, and I was just gonna comment, a couple things. One thing is that, this ultimately translating into lower premiums to our employees is a little bit of a long-term journey. So, 4 months into the plan, we're still trying to kind of get things stabilized. There's a delay in people utilizing care. But part of this presentation that somebody else will present on a little bit later, we do have a financial component of this presentation. So we are trying to tie it together. But yeah, some of this is, happens over time. How many surgeries can you prevent? How many heart attacks can you prevent? 5 years down the road is not going to be an immediate, okay, we're going to reduce premiums tomorrow. Does that make sense?
Sure.
And the year before we got here, we've been going like that. We got to get like this before we kind of start going like that. We're running $1 million a month over budget. So I think we are starting to see a little
We are
stabilization.
starting to
So,
see.
big picture, there's two reasons that we did this, and Mr. Chairman, correct me. One is to stabilize the cost that we were incurring for healthcare. The other is to provide high-quality care to our members, right?
Yes.
So we should have on those two things, those are the two things that I really expect to learn from this time, right? Number one, and I'm seeing you guys are doing a good job on explaining exactly, we are addressing these issues. This is how, there's some nuts and bolts here. We're showing a comparison. You guys are showing me you guys are doing a good job. I can, just to be frank, I can do without a testimonial every time. You guys are here already, right? So I get testimonials all day. Every day somebody calls me about their health insurance, right? And their number one question is, we're paying so much. I get paid $40,000 a year. I pay $1,000 a month in healthcare, right? That's my number one concern. So if I hear that 5 times or 15 times or 20 times, then that's going to be my number one thing that I always address and ask about, right? The other thing is I get complaints about the healthcare. People are still transitioning emotionally from what the provider past to the provider now. So me, I don't have any
Say that again, who is?
Just people in general.
people in general.
Oh,
when they
no, I thought you
address
meant the
me-
providers.
No.
Okay, no, I just didn't,
So-
misunderstood you.
So I don't wanna hear so much about the past provider anymore, you know, I just wanna, this is good information what you're giving me. I think it's a little sales pitchy. So every time we come here, if we do this quarterly, that's just my comment and that's my address. I agree, Vice Chair, that it maybe, you know, these two things will be married and they may be, but those are my two concerns, and in the past ones, we really didn't address that. So I wanna make sure that I'm addressing it early so that we hear that, because that's a district question maybe, but at some point that has to be addressed, that we had two reasons for doing this. So all of this should be two arrows pointing in those two directions, I would imagine.
Dr. Pace?
And certainly, we appreciate all the board members' comments and providing us with direction as we move forward for our next presentation as a quarter, and we'll take that to consideration. I will tell you that part of our purpose today in providing a little bit of a sales pitch or sharing some of those positive testimonials is because we've heard the same things that you've heard about people who are still struggling through the transition to the new system. It is a bit more cumbersome. You know, it's not just you call one person and go anywhere you want to go and life is good. There are more limited choices, but we have a system of care through our multiple facets of this provider that are working to provide high quality care at manageable cost to our employees. But it is more cumbersome. We just have to make sure that we're keeping you all abreast of some of the good things that are happening, because people don't call and tell you that. But we certainly take into consideration your feedback as we move forward. And as you said, we really have that two-pronged approach. Better care for our employees at costs that are manageable and sustainable for the district and provide more money in the pocket for our employees. And so we'll focus our efforts on that moving forward.
Mr. Melendez, and I know you got a comment, Barry.
Yeah, 'cause I saw a clinic that had a pretty cool idea, because we're talking about getting people to go in. Instead of being open Monday through Friday, they're open Tuesday through Saturday, and like Saturday full day, because a lot of people work. And so a lot of times people don't come to the clinic because they're scared to take time off of work or talk to the boss and schedule it off. Especially if we're at school and they're a teacher, they can't take off. I mean, I guess they could, but they have to call a substitute teacher and it creates a little bit of chaos. So I think we do like half a day on Saturday, but we consider just like eliminating Monday altogether and doing like a Tuesday through Saturday and have like a full day on Saturday to try to capture as many employees as possible.
Yes, we would consider that if we had the full utilization from Saturdays. So that is something that we would consider in the future. Getting rid of a Monday, I don't know if we would do that, just
We
based
have a
off.
volume on each
Monday's
day.
the busiest
And I'm just
day,
curious, I mean,
yeah.
I'm just come up with
Yeah,
a
no,
theory.
just
I'm
I mean, I think that the 6 days a week is it works, and the Saturday for a same day type of appointment, as we see that increase, then we would come to the district to say, hey, we would like to open up a little bit more.
So we're seeing a relatively flat volume on a daily basis. 'Cause I see the monthly reports, the total patients per month, but are they literally scheduling more or less the same every day?
Sorry,
There's
what's
so
the
many
question?
spots
No,
to
no,
fill.
there's some days that are busier than others.
Yeah, you know what I'm saying? Because I'm pretty sure the clinic didn't just choose Monday on purpose. When I just happened to see one. I'm just using it as an example, but it's a real life example. I mean, I talked to them. They're like, yeah, not too many people came on Monday, but on Saturday I'm booked because everyone wants to come on Saturday because they're not working.
Yeah, and if we saw that trend, then, we would come to the district to ask for additional hours on Saturdays. Because, these providers, are on your dime, yes.
And there are full-time employees, right? They don't work at another facility, another time, right? And they still are full-time. They do full-time for us.
They
Yeah,
work
they're
for
40
Rosen-
hours.
They work for under Rosencare.
Yeah, if they're 40 hours, but if they want to, cover what is called PRN or just on call, sometimes they do. They can. Because the healthcare system right now needs a lot of providers.
Barry, do you have a comment, or do you?
Yeah, thank you for the commentary from the three new board members. One of our missions, the last meeting of this, was to bring you up to speed with the different direction we've chosen to take in concert with your administrative staff. But you're right, Mr. Osceola, we were not hired to save money. It's easy to save money. you raise deductibles, you shrink your network, you limit access to care. And the problem is saving those dollars creates significantly more cost overall for a health plan because people don't take their medicine, as was mentioned, because they don't take care of themselves. So our objective was to remove or eliminate or minimize barriers to care so that people would be in a position to take better care of themselves. That's why when they go to the clinic, it's free. That's why they have a much lower, our health plan design that we built with Dr. Pace and Sarah and Lauren and the staff basically took for the first time in a while, my understanding is, took nothing away from the benefit package for people that wanted health care, but created opportunities for employees to have much lower out-of-pocket if they come in line with better outcomes for health plan.
Barry,
It
let
is
let me
deeper.
correct one thing you said. You all were very much hired to save us money.
Well, there's two ways to save it. That's
Yeah,
my point.
but making a statement that you weren't hired to save money undercuts every conversation I've been in with the board and the superintendent and in doing the contract. The ultimate goal was to get our employees healthier, which in the long range reduced all the cost and saved us money. And never forget that. And members of the board, as long as I'm sitting here, I'll keep repeating, that was a fundamental premise of this board moving in this direction.
Without sacrificing care.
Exactly.
Quality of care.
Well, and that's my point, and forgive me if my opening gambit was a little glib. What I'm saying is you can save the wrong money. It's easy to save money up front at the expense of costing the plan and therefore your teachers more over the long term. And I think I can say uncategorically that you would not have achieved your stated goal, Mr. Arguello, under the former administrative setup. It just didn't happen.
Agreed.
The good news was you're only going up 8% in that world. We're actually trying to make a impactful difference. This year, we're saving the employees money on their co-pays, the pharmacy and things like that. But last year, the last plan year, in spite of the fact that we were tied to the previous administrative contract, for the first time in 8 years, we came in under budget. Now, what happens for the money that's saved at some point in time with the guidance from Dr. Pace and the staff will surely lead to your second objective.
I don't want to speak for Mr. Wade, but I think that's what I don't think he's questioning what you're doing. I think he's questioning, show me the data on that.
And we are at a cusp where we will be able to show more substantially the direct financial impact of what we're doing, and I think that will address y'all's needs. A comment on what Kenneth, your health center costs are going up. Is that good or bad? I think it's good because they're providing more services, and every service that is provided in that health center is done and performed at a dramatically lower cost than it would be in the open market. And it goes without saying, as Kenneth so well pointed out, the more people take care of themselves, we bend down those outliers that are the result of people not taking care of themselves.
And if we are indeed providing quality service at lower money, we want to drive all the volume we can get there.
Yeah.
The last clinic, the last group we had it was like they had a budget and they felt their budget was 20%, I'm making the number up, 20% cheaper than anything else. But I couldn't get them to say, well, if you do $10 million worth of business, we'll save twice as much money as opposed to 5. So that's what we should be, hopefully, this is considerably a better deal and we drive more volume we get there out of $60-70 million worth of cost, we should be better. So that's kind of what he says the cost is going up. We're spending more money.
Yeah.
So, Mr. Bass?
Oh, you can turn it off.
I can turn you on. It better be nice.
I think we're moving down. We're obviously moving in the right direction, and I do see the satisfaction surveys, and satisfaction surveys are always good to have. But can we survey our employees here at the district to ask them? Because I know there's probably employees that they're not gonna say anything not to rock the boat. But the way I would think we could learn from our mistakes, or maybe mistakes is a harsh word, but if we can have surveys that go out to all district employees and have them come back and say, this is what I like and this is what I don't like. Do we do that on a regular basis, or is that?
We are actually working on a, what I would describe as a secret shopper program that's gonna follow up in random samples of employees with each service that's being provided by each provider to tell us that kind of information.
Because that's only gonna make your job easier, I would think, if you could see, well, here's where we're faltering, and you have a large number. Because like John said, we do hear from people, and
And you'll get the benefit of those reports.
Chairman Thacker, if I can share one other thing before we move on. Talking about marrying this information up with the financial data and where we are compared to budget. I do want to remind you all that in your packet tonight is the monthly financial statements through December. One component of those monthly financial reports does compare where we are with our health insurance program to what we've budgeted. So I'd be happy to walk you guys through those reports in more detail if that helps. And if you have any other data that you want or suggested reporting formats that you want, just let me know. I'm happy to kind of get that information to you in whatever manner makes the most sense.
We also have taken it upon ourselves to redesign and repackage the reporting for you as a board, so you can have a better dashboard and profit and loss statement on what's going on in the health plan. That's part of what I'll be talking about in a minute.
On to the financial update.
yes.
Actually,
Okay, all right. And thank you all once again for just having the courage and the desire for, stepping outside the box and taking control of your healthcare plan. Your employees continue to save money, the district's saving money, and we're increasing the quality of care and outcomes. Just to give you kind of a frame of reference regarding savings, this plan ultimately is pretty similar to the Rosen healthcare plan. And I was looking at Rosen's numbers this morning, and we saved close to $500 million over the last 30 years. But a large portion of that has been in the last 10 years because we just have more employees now at Rosen. So about $250 million in savings over the last 10 years. And what excited me about that is you all are about twice the size of Rosen. So your potential for savings are dramatic. And it got me a little excited. I wanted to kind of share that. On this, on this page right here, I think the key metric on here, if you go about halfway down on your left side, and you'll see PEPM, total expenses. That's per employee per month cost. And so if you look back at this 2017 year, you were at $772 per employee per month cost. The following year, you went up to $815. And then in our first 4 year, you went back down to $780. October through December, we're at $562. But I want to clarify something. There is a natural lag when you turn off one plan and kind of go to another. So when we turned off Cigna and we're going to this new plan, there's a lag that takes place, and that will settle over the next couple of months. And so your 562 is likely understated, and that will go up. But we all feel, your advisor team, the medical center staff, all feel that when we land, when we kind of reach that point where all that lag is kind of resolved, we will be under budget. So I just wanted everybody to know that. The rolling 12-month, Carolyn, can you go to the rolling 12-month? Okay, so January of 20 through December of 20. I think the key metric here is your far right-hand column. That shows your cost compared to budget. And you can see it for each month, but when you aggregate it down that gray line about halfway down, and it says year to date, and I believe that says 93%, that's basically saying your cost is about 7% lower than the funding is. And so that's a good thing.
Anyone who can't read this,
Yeah,
call
I'm
the
telling you,
clinic for the eye doctor.
It's tight. It's
Be me.
It's part of the
Well,
reason
it's
we're
interesting.
redesigning the report.
It's interesting. I printed these things out, and I'm having a hard time reading. I apologize for that. We'll get better on that too. Carolyn, if you'll go to the next page.
Question quick on the
Oh,
first
yes.
slide. To make sure I'm interpreting correctly. The one before that, would to show the summaries,
The first slide, Carolyn?
the first slide did.
Yes.
So I understand that there's I don't know if that's tannish brown highlight, that $10 million and the $8 million, and I guess that's more for Sarah. Was that when we subsidized from General Revenue Fund or something to get into it? How come nothing was subsidized the following year? Because total expenses were still kind of more or less in line. Where did we get the extra money to pay?
The expenses were in line with the budget, so that no additional money
Oh,
was
because
necessary
we
to
were
put in.
subsidizing so much, we just put in a higher budget the following year.
So we actually got our expenses down.
Yeah, but not completely though, because the first year was 59, this is 58. The first year we gave $8 million to subsidize it.
Okay, so part of it was the increase in the funding. So if you look at the funding, it went up about $4 million. We had increased our board contribution, so it's not showing up as that one-time lump sum, but it was that year when we had actually gone ahead, because we had put in the last couple of years prior to this, we had put in $3 million, $3 million, $6 million, 8.5, 10.5. So in that plan year, we increased the employee board contribution, and the net total was about $3.5 million. So that increased the
How much
funding
money
going
was in
into
pot?
the
Okay,
plan.
so it's not like.
So it was a combination of putting more in on the front end, and also reducing the expenses from what the trend line would have been.
So there was funding, but we just don't call it additional funding. You just have to be smart and know that we put more money into it up front.
We
So,
increased
yeah.
the employee board contribution.
That created $3 million, but then the need to kick in an excess $7 million is
Not
where a
happening.
reduction in expenses can.
But if you look at the expense line, we were able to reduce expenses even in that first year. We went from 59 to 60, almost 64 million, back down to about 59 million. So we were bringing it down, but there was the additional contribution as well.
Right. And so we're not projecting an additional contribution this year either, then, right?
Right. We're not expecting to have to put any more in. The question is, how much can we start that trend of
And that's kind of what the chairman was alluding to earlier. We're kind of plateauing. We're not really plateauing, but the thing is, we're not digging a bigger hole, is what we're saying. So we're not expecting either additional funding at the end or increasing the board contribution next year either, right?
Right.
The front end or the back end. So for the next budget, we're not planning to do either one. So in essence, we are kind of plateauing to a certain degree.
I'm sorry, we are.
So in
what?
essence, we are plateauing to a certain degree then. So we are stopping the bleeding, in other words.
Correct.
Yeah, but we're expecting to come under budget again. So the more we come under budget, then that differential is there. That's extra money. That's
So
extra.
last year was kind of the plateau to stop the bleeding. Now, this year, we're hoping to start seeing the decline.
Carol, can we go to slide
3
18?
months.
So slide 18 is very similar to the 12-month rolling, except for it is your current plan year, October through December. And again, going over to that right-hand column, you want to be under 100%, right? You want your cost to be under what your budget is. You're at 74% on the aggregate, but remember, I told you there was a lag, so I think that's artificially low, and we will over the next couple of months we will I believe find our where we kind of land, but we do feel confident it will be below budget. Carolyn. The next slide here is your large claims. It's a large claims report. We can slice and dice this any way you all would like it. These are claims that happen to be over $200,000. So there are 13 claims here that account for, almost 10% of your cost. And one of the reasons for showing this is kind of a precursor to some slides that Barry will be doing for us in a minute. Your past program, we feel, did not aggressively kind of attack and have a management plan to keep these claims, down. So Barry will talk about how we can actively manage these claims better to reduce them to to hopefully in the future when I run this report there'll be fewer claims and the dollar amounts will be less. Barry?
Thank you. Under the prior administrative, yes, sir. Did you raise your hand, Clarence? Okay. Under the previous administrative platform, the philosophy brought forward was that the claims data that represented what was going on with your health plan did not belong to you, it belonged to your service provider. And I think this list of high claims, we as advisors were able to find out about that, but after the horse had left the barn. And I want to remind everybody that today was tomorrow yesterday, and it's going to be tomorrow in a day. And our approach is very data-driven, so we're very excited that we've built out a database system, which Mr. Melendez, as I mentioned to you, is independent of our influence. It's raw data, and it says what happened very explicitly. So I'm not here to go into detail about claims, but to give you a glimpse of what we're building out for your future consumption. This first claim is very reminiscent of what we would see under the prior administration. It is a historical look. It talks about what were your claims by charge type, hospital versus outpatient versus physician. On the right, it talks about what was the impact to the district versus the impact to the members and what they spent. Lower left is where were your claims arrayed between employees and dependents. And on the right, the billed PEPM versus the allowed versus the paid. And that's all good information, but again, it is a rear view mirror. And our approach and view is that the data should be more like a GPS and tell us where to go. As an example, we know now, well, let me digress. Last year, late in the year, we found a $2 million claim that had been going on for a year, and it was well beyond our capability to impact that cost. Upon review, we think we could have had that claim processed and paid for under $300,000 if we had had a chance to control where it was going. Right now, we know that we have 2 kidney transplants coming up over the next 3-4 months. And well, I'm just going to get to that. But the kidney transplants under the old regime would have happened, and we would have been presented with a bill in the neighborhood of $350,000, give or take. And because we know they're coming up, we were able to get ahead of it and negotiate a direct contract for $75,000. That's an example of using data to get ahead of what's going on. As Lauren and Carolyn mentioned, we also have 2 bone marrow transplants. So we're actively seeking the most effective place to have that done. And I assure you, we'll save a lot of money by being ahead of that claim rather than seeing what happened to us 6 months from now. Hyperlipidemia. And some of this is duplicative of what Kenneth is doing inside the clinic, but it's for the rest of your population. But as an example, here we are 33% above the national benchmark for incidence of hyperlipidemia. We do not have a particularly robustly healthy population. It's part of the reason the costs are high, part of the reason the opportunity likewise is so high. Excuse me. Note at the bottom, we have 165 people who, in the 12-month calendar year last year, did not have a lipid profile who are suffering from hyperlipidemia. We have 474 that are not on medication. Part of the reason we're trying to make access to medication more affordable is to get these people to where they can afford to address their hyperlipidemia. And gaps in refills, which we track, we had 314 people that were on medications but had some reasonable gap where they weren't getting their medications filled. These are, now this is the dashboard. We have the ability to drill down to who these people are and to put systems in to have someone call them and say, hey, is there a reason you haven't filled your script? Is there something we need to do to help? Can we provide better service for you? Diabetes, you are subject to the same problem. You've got 23% last year lower, 0.23%, excuse me, than the previous year. That's a good thing. But we're 36.6% again over that national benchmark. And we are redefining our benchmarks to the school systems in Florida or a more relevant benchmark. This happens to be, Carolyn, what is it, 500,000 people that are in the Deer Walk database nationwide.
I think with that new acquisition, it's now like 3 million, but
It's a lot of people.
Yeah.
But it would be better if we could compare you to what's more relevant in your region. But again, as Kenneth pointed out, inside the clinic, we've got 121 people that have diabetic markers in the data that have not had an A1c test done. And we have a staggering 401 people whose HbA1c is not below the magic 7%, Kenneth said, is what makes for a healthy, as they can be diabetic. So it's this data that we look at, and then we can drill down and we can do something about this. That's a significant difference in the approach we're taking. Cancer protection.
Hi, I'm sorry to interrupt you. I
Yes,
just don't want you to get too far and then my question isn't relevant anymore. So just so that I understand, this dashboard that you have is being used by staff in order to find people or patients that have some issues that we can possibly mitigate and then make a connection with them in order to reduce or to mitigate their being a possible issue later. Is that what this dashboard is doing?
Part of the reason we call ourselves Mitigate Partners, yes, ma'am. But it is for that absolutely on the chronic side.
Yeah.
But in the prescription data, there are markers that tell us something big's getting ready to come, like a kidney renal problem or something of that nature, which in addition to addressing, as Kenneth and his staff are doing so well inside the clinic, to bring those same types of protocols and observation and action to the non-clinic, part of which would be, hey, have you thought about going to the clinic? You know, we want to drive more people to the clinic.
What's the conversion rate when you make contact of them actually coming in or, you know, using the preventative measures?
I'm sorry?
Conversion rate, so let's say that so let me just give you an example. You have 121 people that no annual HP1AC test done.
Mhm.
You're contacting all of them? No.
Not yet.
Okay.
We've only been on this platform for 4 months.
Okay.
Now, to her point, do we have like a dedicated case manager who's just kind of looking at this and making a contact? Is there like a point of contact within you guys? I don't know, so many companies, entities out there. But to her point, is somebody monitoring the data and being that liaison and calling individual people? Not looking at the data.
We will be there very quickly. We're at the beginning of the journey. And again, I just wanted to show you, we just got these reports
Yeah.
2 weeks ago. And the data has to be relevant, meaning we have to believe it, and there has to be enough experience over time in there for us to start driving this ship in the right direction. And I'm not talking about next year, but over the next 60 to 90 days, yes, we're going to be using our partners at MAP and at the TPA Aether to reach out and start guiding these people. Lauren?
I would just like to clarify, when you said staff, it's not the school district staff, because I don't want any employees thinking that we have access to their PHI. We don't. We only step in if the employee contacts us. So if anybody's watching, I just want to clarify.
Oh, thank you.
We already have some outreach going on for the high cost specialty drugs that are available through the International Drug Program. So each month we kind of say, okay, right now let's see how we can reach out to certain members on ABC drug. And then so the person who's on that committee goes out and attempts to reach out. I'm not sure if you know, but I get a lot of spams a day, I get a lot of calls a day and emails. It's hard to reach people.
No.
So there's a lot of attempts that go on to reach them, but we're trying to, at least on the high cost ones first. And then we can talk about the medication refills and things like that later.
Kenneth has had the luxury over the last 15 months to actively run his world,
Yeah.
the health center. And he has a dedicated person to make the calls Carolyn is addressing. We have had to rely on this rear view mirror data dashboard that Cigna gave us, and there's no way they were going to tell us who, what, when, and where. They were just saying, here's what happened to you.
Right.
So since October, and as the data has built up, we now have the ability to take the kind of actions for your non-health center population that is so ably being managed internally. It's all about the data though, and that's my point.
If I can just add one thing. When we were with Cigna, gathering this data was a Herculean effort. And it was a big question of who owned the data or who did the data belong to. And there is no longer a question that this data is the school district's data. So if these guys leave tomorrow, the data is here and it's ours, and whoever would follow could use that data. So very unfortunately, in the prior agreement, it was unclear.
No, it's ours in the prior agreement, they just wouldn't give
They
it
just
to
don't
us.
acknowledge that.
We appropriately dealt with them legally to get it.
You know, other things, type of things we looked at for another client, we recently reviewed 3 claims at a hospital to the west of us here, Great Hospital. There were $760,000 in billed charges, but upon review of the itemized bills, there was close to $140,000 of charges that shouldn't have been on it. Nobody's been watching this. We're watching it. Our whole mantra is active management of your health plan. We okay?
Yep.
And again, you get the idea. I could stop now, but for under cancer, as an example, we have 1,631 females in your population with no breast screening. That's a dangerous situation. Even Kenneth would tell you that. We have 1,848 who have had no cervical screening at all. And we've had 402 males that have not had a PSA test in 12 months. That's a problem. We're gonna do something about it. We also had 3,051 people, whether they were busy or disinterested, who did not take advantage of free preventive testing. So again, actively managing your program, we're going to be identifying these population cohorts and doing something about it. Outpatient imaging, which is where we have a great program in place. Our cost, because for the most part of the year, this was based on the prior contracts under the administrative program, we were 14% higher than the benchmark on MRI scans and a staggering 65% higher on the CT scans. When we got into the historical data, we actually saw CT scans in excess of $30,000. They cost about $1,800. Our contract has a dramatically lower cost on that. But because of the work, our MRI scan count is 81% lower than the benchmark, and the CT scan is lower than 36%. But to your point, Mr. Arguello, importantly, what was an average cost for an imaging to the member of $569 is now zero if they will use our solution. We want to save money for everyone, to Mr. Kruppenbacher's point. So then we look at the intervention opportunities. We're looking at the top 5 drug switch savings opportunities, which we are actively managing. That can be switching from brand to generic. It can be switching from domestic to international, but we're observing that. We actually have 41 people, the data says, or have the potential of having rising costs over the next 12 months. And we're certainly going to be focusing on them. And we have 972 people who have utilized the ER, which is the singularly most expensive place you can go for 4 hours of healthcare. Well, 20 minutes of healthcare with a 4-hour wait. And then we're looking at admissions, and we're tracking the top 5 avoidable admissions. And all this is simply to say that your team here is data-driven, and we want to use the data to drive decisions and actions that will put you in a position to give the teachers some relief on their premiums, but in the short term, saving them tons of money when they follow protocols that will help us save that money for the school district. And again, just a glimpse. The next time we hope to have some properly formatted and get them to you in advance so you can develop your thoughts and questions and give a deeper dive and a more connectivity, as you 3 new members all requested, between what we're doing and how it's going to positively impact the financial outcomes for teachers and the school district. Thoughts, questions? Yes, sir, Mr. Bass.
Not really exactly related to this. I read an article yesterday. They were talking about just the regular seasonal flu. People tracking it over so many. They said the regular seasonal flu is exponentially just I mean, almost non-existent now. The hospital visits because of this. So I don't know that maybe that's a good positive thing that we're seeing as an outcome because of all of this. So
Yeah, and I mean, so Lauren and her team and Mr. Larson went out and gave out those flu shots too, from a preventative standpoint, because we were predicting there would be a flu. But because of COVID and the masking, the washing the hands and social distancing, all that, yeah, we've seen it plummet, which is a good thing.
yeah, that's good. Well, it's a cost. In the end, I guess cost savings because
Yes,
you don't have that many people going to the hospital for a seasonal flu.
Exactly. Hundreds of thousands of people die a year because of flu alone.
But after we fix COVID, we're gonna go back to hugging and kissing a lot more.
They get the flu again.
Either that or you can go to the fair next door. I'm driving by this, I'm going, are they really having that in the middle of the pandemic, that's,
Looks like fun.
I try to educate people on ER visits, because I'm very familiar with that. And I know that the ER visit is gigantic, but sometimes you can't avoid it. If you're in an ambulance, I think we talked about it during the last workshop. Are we tracking that? How many ER visits are ambulatory versus self-admitted? Because if they're self-admitted and that number is not going down, then at the district level or somebody, I don't know who, you guys pick who, needs to educate those people and let them know, hey, go to an urgent care instead if it's after hours or something. 'Cause I know there's-
We track it, we educate, we do, that's like our biggest,
Yeah, very well
Biggest-
said.
So I would like to see that, so maybe like our own little PowerPoint slide, okay, the number of ER visits, how many ambulatory versus self-admitted.
Carolyn, would you make a note of that as a specific data point for Mr. Melendez?
Yeah, it's very, very well said.
And, you know, because we have a couple of bone marrow transplants, which aren't cheap, and a couple of kidney transplants, which are cheaper with the system we put in place, but still a little spendy. To Ashley's point, to suggest that we're 26% below budget right now is a little premature. But once we seek a normative equilibrium, I think you're gonna find we're gonna be, I don't wanna predict 8, 11, 12% below budget because of the methodologies we're putting in place. Thank you.
So, one of the other initiatives we've been doing over the last several years is the wellness incentive. If employees do certain things, then they can save on their premiums. So we moved from $25 per check for our lowest plan to $0 for that employee. If it's a family coverage, it's usually a $50 differential on it. And we are doing this so that we can get more people to do the things we need them to do. So that 3,000 population that's not going to getting their primary care visit, which is very important if you listen to Kenneth, then we're pushing them to do that. So this year or last year, we actually instituted, it was gonna be 100 points, but because of the pandemic, we reduced it to 50 for last year, but this year we're back to 100 points. So we sent out communications about 2.5 weeks ago now, and in the first week of employees logging into the system, an online system, we had close to 500 employees just do the health risk assessment. So the health risk assessment gives them 25 points just by answering health questions. Takes them about 10 minutes to go and do it, but they're already a quarter of the way there to get their rest of the points. For each visit that they do that's appropriate to their age, they get certain points. They also have up to 25 points that they can do for that are self-reported. Self-reported as simple as checking their pay stub, volunteering for your community, doing a 5K, doing virtual classes. So for the next few months, we decided how do we get the employees more engaged during COVID because their stress is very high. Our classes are very low for proper social distancing for our fitness classes. We're not doing the 5K for the same reasons. So you'll see in your emails every week sending out different classes virtually for employees to be able to attend to get their points. And it's not only going to help earn the points, but it's also going to help them. So how to deal with stress during the pandemic. There's classes from our Florida retirement system partners. There's classes from our EAP partners, and then there's classes from MetLife who does our life insurance. So they have a big retiree wise, which guides them through all steps from basic budgeting all the way on how to save for retirement. So we hope that if the employees can do all their points, their regular deadline is by July 31st, so it's a full year back from August 1st to July 31st. But if they get it done before the end of the school year, they could enter to win a couple of raffle prizes that we got from our giveaways that we got from our partners. So you'll be seeing those. Employees are usually pretty involved with those from us. But for the HRA, this is basic questions. It encourages them to go out and get more things done. You get a colonoscopy, you get some points. You get your yearly physical, your mammogram, and whatnot, you get your points.
great. Any questions regarding the wellness portal?
And if you need help with that, just let us know and we'll guide you through the portal because you also can get the incentive.
Great. So here is our benefits wheel that we call it. And we're gonna go over a program right now that we have, Barry referenced it with our great imaging program called Green Imaging. And I know the numbers are super small, and to get it on one page, that's the way it is. But what this is just a report saying that from January through 2020 through December 2020, with green imaging, that we saved the school district about $1.5 million, just in imaging costs alone. So when someone uses green imaging and engages with green imaging, not only are the costs for the school district lower, but also the member pays nothing for that. So if they need an MRI, a CT scan, a bone density test, an ultrasound, whatever it might be, of those large images, they can contact Green Imaging. It's very simple to use. I've used it myself because we have it at our group, and they take it over from there. So again, that was our first year results. That pretty much was with the incumbent people using the incumbent administrator there. And here's some examples of the difference cost between an MRI within Green Imaging and on the outside, what we used to pay before. Vintegra is our pharmacy benefit manager. We call it a PBM. So they administer all of our pharmacy program behind the scenes. You still go to your Publix, your Walmart, wherever, but they do all the behind the scenes for that. We also have a consultant working behind the scenes for us called SkySail RX. And they are really an auditor or watching the plan to make sure that the plan is running according to the contract. We wrote the contract a certain way. I want to make sure that the rebates that we're supposed to be getting, the discounts that we're getting, how we're paying for it is actually what we actually are paying. So this is really from October 1st through December 31st and what they talked about. And here, I'm so dry mouth, excuse me. The first thing that you notice is that we have about an 85% generic utilization, which is good. We've seen it a lot higher with other organizations, but that is pretty good. We've seen organizations in the low 90s, 93, 94%. So I say that's decent there. When we talk about what percent the employee pays versus what the employer pays, the group is paying 86% or 88% of the cost of the prescription drugs, and the member is paying 11.7% of that prescription drug. And here is the difference between of the brand names, the specialty brands, and then the international drugs, what percent of those are being used. Here's a nice multiplier for you. So take a generic drug. So brand name drugs compared to generics are 17 times more expensive than a generic. Okay? Specialty drugs are 12 times more expensive than that. So specialty drugs are on average 204 times more expensive than a generic drug. So when you have questions about where is our plan, why is our plan so expensive, this prescription drugs are a huge factor for costs for our prescriptions. Yes, Barry?
We want to point out, you probably already know this, but a lot of the drive to specialty has to do with the fact that it's injectable rather than taken orally. So a significant portion of that additional cost is really a convenience factor. And yes, it is more effective if it's injected, but I suspect not 204 times more effective.
So here's cost by channel and drug type. So here we go. Specialty claims account for less than 1% of prescriptions, of scripts, and 41.5% of our overall drug spend. So less than 1% of our number of prescriptions, but 41.5% of how much we spend on our prescription drugs. We did a partnership with Publix this year, and we did promoting with Publix. We said if you go to Publix to have your prescription filled, we had a lower copay, and a lot of employees are engaging with Publix. So they are, the most of the prescriptions are weighted to go to Publix right now. So that's a really good thing. our international drug program, in 2 months, where they projected that we saved $107,000 just in 2 months in our prescription drugs that we have going on with that program. These are most of the medications that we have coming in that people are using on that. And again, a lot of that is from the outbound reaching out program that we have going on through that, and by word of mouth. We have some members of the benefits committee that are huge champions for us, and because they have it and they use it, they've been telling a lot of people about it. So it's a great program for that. Specialty rate performance. So again, I talked about how expensive those specialty drugs are. The specialty drugs, Humira Pen, Stelara, Hemlibra, are 14.2% of our overall drug spend. And then all of the other products that for our entire benefit for our pharmacy program is 85.8%. So they're very specific drugs for a very specific condition. There's no other drug for that. And the people need that condition in order to live, or to live a life of some type of quality. But if we can get it and get it at a lower cost and more convenient, we're doing everything that we can to do that. With the Hemlibra, we're able to secure that with a unique program through a hospital program and get some unique pricing on that. So we get a little bit of a less cost on that right now. In takeaways and opportunities with what they told us, that the current discounts, the average wholesale price discount that we're getting right now, they are overperforming. So right now with what the discount is written into our contract, we're getting better discounts than the contract is saying. Right now what they're saying is that they estimated that we're saving about $145,000 under our program for the first 3 months. And then with our international program, an additional $100,000 for the first 2 months. And again, that was brought up from our pharmacy consultant that we have who's watching and bird dogging our overall pharmacy program.
And is that in comparison to the prior administrative contract?
We don't have any comparisons to our prior year. We have requested that, but we don't have it yet. So hopefully when we do our new report, we'll have more, 3 months more of data, so we'll do it for our next one too.
Skycell did say to me that we're projected to save $2 million over our previous program the first year, as long as we continue going to where we are for the pharmacy.
Christina, you have a question?
Yeah, I do have a question on the takeaways, and it just might be that I'm not reading the data correctly. You can just help me kind of demystify it. So you're saying current, give me the acronym.
PBM, Pharmacy Benefit Manager.
Okay, so estimated at a cost savings of $145,000.
That was just for the 2 months that we're doing.
I understand. So that's what they're reporting?
Yes.
International RX program is reporting for the same data, the same time?
And our international program is a separate company.
Okay.
And so the program here, they have to report, because it's coming from international, they send us reports of what we paid for the drug, and we have to say what that market price is in the United States, and we have to kind of calculate what the savings would be. And so that's what we report on that.
Got it. So just so that I understand and we're on the same page, $145,000 is going to be the specialty drugs, like not using, going generic and whatnot, and the $100,000 is all of the drugs that we're getting internationally.
Correct.
Yes. Okay.
But wrapped all together with a nice bow, our pharmacy consultant estimates $2 million
Got it.
for the
Thank
whole
you.
thing for the year.
Understood. I appreciate it.
Mr. Bass, and then I'll come back to you, Mr. Melendez.
Just a quick question, are there any instances that you can recall that one would, they would deny use of a specialty drug or a brand name?
If it was not medical necessity, or if it's not on the formulary. So if it's not on the formulary because of effectiveness, or if there's another drug that is more effective or has been known as not.
So it could be, I mean,
It could be.
It could be denied.
Yes.
So,
And when they give that denial, because I've had one instance that an employee contacted me, they give the physician the alternative drug for them to try it first. And if that doesn't work, then they go through a process and maybe in the end, they end up with that original prescription.
that was just, and when we ask questions, these are just questions that have been brought to me over the last, month or 2 months, or
Yes.
however long, and that was one in particular, maybe there was a person who wanted a specific specialty or brand name drug and was denied, and that kind of left a, bad taste in their mouth because they were used to
And-
taking that specific drug.
That happened under Cigna as well. Cigna had their own formulary. In this instance, we can give input, and that's what SkySail does, gives input into that formulary with Integra. Before, we didn't have any control over that at all. And at one point, there was one employee that did contact me, and I went through Ventegra, and they gave me a response, but the poor employee was still in a bad situation. So I elevated to SkySail. SkySail stepped in, and that employee went back to the original medication. So it's things that we have to work through. It's a process to go on it. Sometimes there's a step therapy saying try this one first before you go to the next one on there. But in the end, the patient gets what they need, and physicians also have the ability to
As long as
appeal.
that process that you're defining is not is extended,
Yeah,
And the good
usually
news
not.
is that process is internal as opposed to having to go
Correct.
to an outside administrator and beg permission or.
And a lot of times, the employee thinks that the physician has submitted an appeal, and we come to find out the physician never has. So that's why the employee thinks that we're taking too long. Just keep that in mind, that sometimes they just don't, the office doesn't submit what is needed, so.
And there are prescription drugs that are out there that just don't cut it as far as medical necessity or effectiveness. So we've had certain drugs removed from the formulary that were on the formulary with Cigna. One of them was Duexis, that was on there. I think we had 2 or 3 people on Duexis. If you want to talk about what that is.
Yeah, so the Duexis is just a combination of 2 medications, one for stomach that you can get generic and ibuprofen. So why are you going to pay $2,000 a month for a drug that costs maybe $20 at the most? The ability that you guys have now to control your formulary is key. The other piece that I want to talk about, just because we see something on TV, that's a $6 billion direct-to-the-consumer marketing that if I had any will, get rid of the thing. Because it ties the provider's hands. Because that patient sees on TV, oh, this drug can help me with X. But they don't listen to that little fine print that your head will fall out, your eyeballs will fall out, all that kind of stuff. But then they come into the provider saying, I saw this on TV, I want that drug. But then they don't know that medication might cost $22,000. But there are programs that are just like the one I was talking about, step therapy. Did we try X before we got to Z? Which saves you money and also helps the patient. Because remember, your population has deductibles and co-insurances that they have to pay. So just because they see it on TV doesn't mean it's going to be something we automatically want to prescribe.
And I'd like to give another example. It's not just the medications, but things that you do get through the pharmacy, which are your diabetic supplies. So Cigna on their formulary had the highest cost diabetic supplies as the preferred brand. So us as a health plan, we're paying the highest dollars because the employee was driven to that highest cost one. We've analyzed it with SkySail and Ventegra and have 2 different glucometers now, and those costs are now generic or preferred and are much cheaper for everyone. The first 3 months, we grandfathered in those patients so they could still get the supplies that they needed at the preferred pricing, but then gave them a warning, say talk to your physician, let them know, and I move you over to this other one so that they can, and we also introduce Diathrive, they can save on the money just moving over to that. It's common, it happens all the time in other insurances. Our employees just never dealt with that because we haven't had this drastic of a change in years.
Yeah, our average test strip, we were paying $2 per test strip that we were having employees test. So if you're diabetic, excuse me, you're testing 3 or 4 times a day. So take that $2 per one. We're now at 27 cents. Through Kenneth's program, And then I gotta figure out how much it is through the Ventegra program, but much lower. And the employees are now getting them for free.
I want to emphasize the Duexis, and again, I talked about the cost of convenience. $20 drug with ibuprofen, which is a form of aspirin, put it together, it's $2,000. And you can just take both of those separately at the same time for dramatically less.
Well, I was having heel issues, and I think the Duexis is what he had. It was anti-inflammatory, but then it was also stomach medications because of the interaction.
Right.
But I have another who prescribed the medication, and I take it to the pharmacy. So how am I going to? The pharmacist is not going to say, "Hey, by the way, you need to do this or that." So.
Right.
So the pharmacist won't say it, but then it will get stopped because of your plan saying that's not a covered product.
Correct.
And then that's when it gives an opportunity to say, do this instead of that.
Okay, but you see how if that were me, and if I was just somewhat naive and I ran into that roadblock and I wanted that medication right then, it would cause some grief on my part, because now I don't know which way to turn. You're telling me this when we're in this room, we all know that, but the little lady or the little man who just wants to get his medication doesn't understand that. So I hope we don't have too many of those obstacles out there, because that looks bad on all of us.
Or where the explanation is not sufficiently
Right, that's what I
provided,
mean.
Is there any case where the generic, sorry, Jim.
This is getting bigger than I thought. It's actually along the same exact lines was my question. How much of this process is driven by the patient versus the doctor? Because I didn't know that patients were allowed to just say, okay, this is the drug I want to take. I always thought you go there and the doctor tells you. And if the doctors are in our network, can we share with the doctors ahead of time what our formulary is, so they don't even put us in that pickle? Because the doctor's just saying, okay, take the most expensive brand because I don't care, it's not on me. Then are we going back there saying, hey, don't go there? Then then they feel like it's a switch or bait and switch. Are we having those conversations with the physicians in our network? Because they'll have to be credentialed to be in our network. We don't just randomly go to people. We always tell people, hey, if you're tier 1, tier 2, tier 3, if they're tier 1 and we approve them to be a tier 1, can part of that process of approving tier 1, tell them, hey, in order to be tier 1, can you kind of this is our formulary, can you kind of prescribe patients what belongs in the formulary, unless there's some kind of exception or medical necessity?
Right, and there is a process associated to that. And as we bring providers into the network and we see that there is either abuses or steerage or problems with prescriptions, we would have those conversations. The formulary is a significant formulary that we have within this program, and we control that at the point of care. But you're exactly right. If we see a problem, then we would notify that.
Because they're not going to be at our clinic, right? Everybody at our clinic, when they get a prescription,
Oh, yeah, they have the
we're not going to have points, tell them, hey, go get the super
Yes.
duper, unless it's needed. If that's the only drug that exists, and there's no alternative.
Correct.
But at least in the health
There's-
clinic, we're not driving them to the more expensive one.
No. And we look for those type of things. We know what's prescribed within the health center from the meds that we prescribe, but also what is written as a prescription, so we can see those behaviors. Number one, see, should we carry that within the health center? But as we continue to tie all of this with data, we're looking at other opportunities associated to pharmacy and the cost of drugs. So, hang on tight, because a lot of those things are going to bring a lot of this together.
Because do you feel, in other words, the last question is, do you feel where's the obstacle? Is it mainly coming from the patient saying, I want this drug, or is it coming from the physician appointing them, or not appointing them, but prescribing that medication tight, and they're expecting their head, I want what the doctor recommended, and you're telling me the plan's not gonna approve it, that's what the doctor recommended. Does that make sense?
Obstacle,
Where's the
right.
ideology?
We don't have a
No.
big obstacle in the
No.
pharmacy right now. At least I don't feel, we don't get a lot of calls about the pharmacy right now.
Your point is relevant. A lot of this $6 billion is focused on the physicians rather than the patients. But I remember one time there was some drug, and it was 3 old guys with golden retrievers in the park. And it said, ask your doctor about this. Didn't tell you what it was for or
Nexium.
anything.
Purple pill.
And I think there's relatively little of that. I might go, hey, I heard about this Duexis, what's that for? And normally a doctor would say, don't worry about it, it's for something you don't have, or that sort of thing. But, Mr. Bass, to your point, we could communicate all of this, but for the 99% of the people that haven't experienced it or won't experience it, and, until 4 months from now, they'll forget about it. So if we have 60 Duexis in a year, which would be a lot, we can handle that retroactively. We can handle that responsively, much more effectively than trying to over-communicate the problem.
Julius?
Are there any instances where the generic doesn't perform as well as the brand?
That's a Kenneth question.
There are some generics that the state requires that we give them the brand, and it's really up to the choice of the patient. I mean, each individual is going to react differently to different meds, like Synthroid and for thyroid, some people react differently. So the answer is yes, but let's give it a try because it's supposed to be within, I think it's like 10%, 10 to 25% effective relative to the brand, but most patients respond very well. That's why I think your generic utilization's in the 80s, 84% or something.
87.
87, which is great. But there are some that, you know what, hey, they tried the generic, they had maybe an adverse reaction to it. There could have been a dye in that generic that really they need to be on the brand, and then that's when we can step in. But again, we have the ability to step in. You have the ability to influence the formulary. You didn't have that before.
There's certain categories that there has to be an offering of the brand name. The member can still opt for the generic. Mostly they're seizure medicines, and the thyroid medicine are the ones that are most common. But in order to qualify as a generic drug, it has to, and the FDA has to have it the same effectiveness as the name brand drug. And then there's people that just want the brand name for whatever it is. So there's a lot of different things that with that. But we always have the ability for those certain classes of drugs that the ability has to have for the brand name to be given out.
And also, Mr. Wheeler, remember that there are the generics can be produced by multiple manufacturers. And so maybe they got this manufacturer of this generic and there was something else in it that they didn't really respond to. So the answer is yes.
Any other questions before we move on?
The last thing is just informational items. We are currently interviewing a mid-level provider to bring workers' comp back out to the health center. We had a couple interviews last week and one yesterday, and now it's in Kenneth's hands to do a final offer to them, but they were all very good interviews, so we hope to bring in, lower those expenses on workers' comp. And then currently we will have 2 RFPs out, so we're in the cone of silence, but just want to make you aware of the schedule. The vision and disability, they're both up, their contracts expired, so those are up for renewal, or not for renewal, but out for bid right now. And that's it, unless you guys have anything else.
Dr. Pace?
Yes, sir, I have nothing other than to say, thank you to the team for bringing this information to the board. It's a process. We welcome your feedback and we'll adjust accordingly as we prepare for the next one.
Hats off to where this laser printer came off. That laser printer is the best because it is microscopic and you can still see the numbers are still there. And
Speak for yourself.
That was a printer on bid from
I have tried bifocals here, so.
and the printer is probably 5 years old, so that's good to know.
Last about 6 months ago. Everything's good.
Okay, based on that, thank you all very much.
Thank
Very
you, guys.
helpful. We will stand adjourned until our regular meeting at 5:30.